Good afternoon, everyone. We've got a packed agenda today, so I think we'll make a start. Um, Welcome, everyone. My name is Lynn Flanagan, and I am a Senior Improvement Advisor in the team. And I am delighted to be able to chair today's session. It gives me great pleasure to welcome you to this webinar on the newly published SIGN guideline on the assessment, diagnosis, care and support for people with dementia and their carers. So before we begin, I'll just start with the usual housekeeping arrangements. Your camera and your microphone should be switched to off, and we've done this to avoid distractions and to minimise the likelihood of slowing down the technology today because we have so many people joining. We will not be using the hands up function for questions, so if you've got any questions, please just pop them into the chat. This webinar is being recorded, so by taking part, you consent to this, and we'll send the recording and the link to that and the slides to everyone who's registered for today. So you'll see you're in for an absolute treat today. We have a packed agenda with lots of fantastic speakers. So without further ado, we'll make a start. So first up, we have the Minister for Social Care, Mental Wellbeing and Sport, Marie Todd. The Minister originally recorded this for the launch last week. So you'll maybe hear her reference that within our video. As many of you know, the launch was unfortunately cancelled because of an electrical fire at the venue, but we felt it was still really worth sharing the video with you. So we'll play the video now. So a huge thank you to the Minister for providing that video for us. And next up on the agenda, we have Dr. Adam Daly. Adam is an Associate Medical Director with North Lanarkshire Health and Social Care Partnership. He's a consultant in old age psychiatry, and he was also the Dementia Sign Development Group Chair. So over to you, Adam, if you would just like to take control.
Great, thanks, Lynn. I think that should be, yes, that's me in control. Okay, thank you very much for that introduction. It's a great pleasure to speak to everybody today about this. As you just heard, there's a huge amount of work that goes into these things, and it's great to have the opportunity to talk about it. Now, to start with something that you probably all know, the reason for the guideline, the whole point of why we're here, is that there are lots of people with dementia. And I chose this, it's a little bit of an older slide, but I suppose it represents the fact that we're now at the midway point of this graph, and things are not going to slow down. There are going to be more people getting dementia. There are going to be more people that we're going to have to care for over the next 20 years before things start to show any sort of plateauing. And it's going to be a different population as well, much different to whenever we released the last set of sign guidelines 20 years ago. And really the main thing to look at here is the number of people in the older age groups. So whereas about half of the people that we care for at the minute are 80 and under, it's going to be about 2/3 are over 80 whenever we get to 2040. So a huge change in the number of people that we're going to treat and the makeup of the people that we're going to be treating. So whenever we get together for a guideline and trying to draw up a guideline, we really want to think about what are we trying to address. And variations was the thing that leapt out whenever we first began this piece of work. These pieces of work tend to begin with professionals, as you probably know, people who see problems or differences in their day-to-day practice that they feel could be addressed by some better guidance and by some better support. And the variations are a huge part of that. You'll see some familiar themes there, I'm sure, around young onset dementia and cognitive and non-cognitive symptoms of dementia. But this was really the start, and things expanded quite a bit from there. And I'll talk about that a little more in just a moment. The aim of the guideline, trying to reduce the variation through evidence-based recommendations on assessment and diagnosis, and care and support for people with dementia and their carers. And then the key bit here, to try and inform and provide benefit to all stakeholders. So quite early on in the process with SIGN, we start to look at the guideline development group, which again, I'll go on to in a little moment. But one of the things that we wanted to do with this guideline was to shift it from being owned by professionals to being co-owned by people who have dementia and their carers and the people who are important to them. And that led us down a path of doing quite a lot of consultation before the guideline actually began. And the key questions which drove our guideline and which drove the work that we did were very much informed and shaped by people with dementia and their carers and families. And that's why whenever we come to recommendations, you'll notice that the recommendations, I certainly hope you'll find are very much person-centered, and that's really what we wanted to achieve. Now, obviously, this work doesn't come from nowhere. It builds upon established work that people have been doing over the last 10 to 20 years. And Scotland has a proud heritage of great work in dementia through the strategies that you just heard about and the work plans that are to come, but also through things like the Charter of Rights. We also have great models of care, which are implemented across the country. And these are things which we have benefited from, but obviously we hope can be improved further still. So the proposal for the guideline initially was a joint application from the Royal College of Psychiatrists, which is who I was representing on the group initially whenever we proposed this, and also from Alzheimer's Scotland Nurse and AHP Dementia Consultants. You might be surprised to hear that it was 20 years since the last Scottish clinical guideline in dementia. So quite a lot of work, as we've just described, has gone on in those intervening 20 years. And there was a strong desire from professionals for something to come about that was Scottish in its ownership and in its direction. Now, we had a number of challenges whenever we were drawing up the guideline. The first among those was limited resources. And by limited resources, I mean limited staff time. So sign guidelines have a very small number of dedicated staff employed by HIS who actually do the work on the guidelines. But the rest of the work, the main part, which is reading through hundreds and hundreds of papers and trying to critically appraise them and then actually writing the guideline, is done by people who are volunteering. And on this group, that was professionals, but also people with lived experience through being carers and folk who support people with dementia. And that meant that quite a lot of the staff pressures that were being experienced in the NHS led to challenges with actually delivering the guideline on time. People will be aware that this guideline was initially proposed just before COVID. So we had an interesting journey as people were trying to cope with their changes to their lives that were brought about by COVID, and also the demands of trying to get this guideline finished in a reasonable time frame. And we also had the added opportunity, as well as a challenge, of NICE 97 being produced. That is NICE's guideline on dementia. And that outlined a number of very useful areas, which meant that we didn't have to go into those areas with as much depth as we initially thought that we might have to, which gave us a bit of freedom and a bit of flexibility to look at things, again, which had a much more Scottish context. And that has really helped us produce a guideline which is relevant to the people of Scotland. So a wee poll for you. Most people haven't read all the way to the back of the guideline, I would think, to see how many people have contributed to the guideline. But how many people do you think have contributed to the guideline? And this is just the main guideline development group, not even the folk who were involved in the consultations. That's great. It's nice to see everybody responding. Okay, I'll stop whenever I hit about 200, I think. Oh my goodness, there's 326 people. So there we go. Right, well, we're up around more than 30. So 71% of people think more than 30, and that is, of course, correct. Just move forward another slide. So we had more than 30 on the guideline group overall. Some people came and some people went due to other commitments, but we had around 50 people contributing to the guideline itself. Whenever we include all of the people who went through the consultation exercise, we go into many hundreds of people who contributed their views toward the guideline. And the consultation exercise is a detailed and very helpful thing that SIGN do. Involving people from all sorts of areas in the country and out with Scotland as well, to give their view on the quality of the guideline and what's recommended. But the actual guideline development group, a consultant in old age psychiatry, of course, I put first, as that's me, but we had a whole range of other folk who were involved in the guideline group and contributed, of course, a range of meetings over the course of several years. And I'm just going to pop their names up on the screen quickly because it's worth saying thank you to all of them. And believe it or not, this is just a selection of the people who contributed toward. We didn't have room on the slide for everybody, but the full list of people who contributed toward the guideline is included in the guideline itself. And I would encourage you to read all the way to the back. I'll be back in a few minutes' time to cover the rest of the guideline, to go into the recommendations and conclusions. But for now, I will hand back to Lynn.
Thank you so much, Adam. That's fantastic. And if anyone has any questions for Adam, please feel free to pop into the chat. So next up on the agenda, we have Karen Graham, who is a patient involvement advisor for SIGN. And we also have Marion Ritchie, who is a member of the National Dementia Carers Action Network and was also on the SIGN development group. So over to you, Karen.
Thank you, Lynn. So I'm Karen Graham, as Lynn said, and I'm going to talk about how we engaged with people with lived experience throughout the guideline development process, and Marion will talk about the carer experience and how she contributed to the guideline. So we engaged with a range of third sector organisations. So we worked in partnership with them, and we asked them to help us to identify what topics our guideline should address. And they made some patient submissions to us, and we considered them. We presented them to the guideline group, who of course considered those topics at their very first group meeting. Now, some of the topics that they suggested to us are listed on this slide. And just for example, the first one here is support and training for carers was something that all the organisations who made a submission felt was important. So what should people with dementia and their carers, what support should they get and what training should they receive in relation to things like managing distress? And of course, the guideline addressed that, and it provides information on how what information people should get, and of course it provides recommendations on the support and training they should get. Something else that was very important to people with lived experience was communication. How should they be communicated with? Who should give a diagnosis of dementia, and what information should they get? And again, the guideline addressed that. Some other things we looked at that was highlighted from those submissions was transition between care settings. Again, communication was seen to be important. What support should people receive during the transition? And again, the guideline looks at that and, of course, makes recommendations but provides information as well. So, in addition to getting submissions in, we of course obviously wanted to work with people with lived experience as guideline group members. So, we went through the third sector organisations again, and we asked them if they could nominate people to take part in our work. We then got one representative from Age Scotland, so about dementia as part of Age Scotland, and they took part in the guideline development group. And we had two carer representatives, Marion, of course, who is from NDCAN, and we had one person from Tide who worked at Tide but was also a carer of someone with dementia as well. We tried to get someone with dementia involved, but we were unsuccessful. So we then had to come up with another way to hear from people with dementia themselves. So what we did was we wanted to engage directly with them to make sure that we were get their input to the guideline and addressing what matters to them. So we held a meeting with the Scottish Dementia Working Group members to discuss what mattered to them. A lot of the issues that came up at that meeting mirrored what we had already gathered from the third sector organisations. So it was really encouraging and reassuring that everything we had on board was what people all wanted the guideline to address. We also had a meeting with About Dementia, Age UK, to discuss the draft section of the provision of information section. And they had a lot of input to that section. It went through a number of changes to get it right. So we had a lot of input from them in that. We also organised a consultation meeting pre-meet with people with dementia to make sure that we were getting it right. So we asked them how we should be running that meeting, what would work for them, what wouldn't, what reasonable adjustments could we make to make sure our approach was inclusive. We also ran a workshop at the consultation meeting specifically for people with dementia and carers to get feedback on the guideline. We presented the information in plain language at that, so the recommendations were converted to help them to understand that and to be able to make them have a meaningful contribution. We also invited people with dementia to peer review our guideline, and we got one person who took us up on that. So, as Adam said, we wanted to make sure our guideline was person centred, and I think the amount of engagement work we had has resulted in a person centred guideline. So, the issues that the third sector organisations submitted to us made us change the key questions. So, there was some wording changes to them. Also, having Marion on the group and the other representatives led to some wording changes as well. The provision of information section, of course, was changed a number of times. So that the issues that were important to people with dementia were included in that, and the infographic that you've seen in the guideline again was changed to reflect the views of people with dementia. So We also had meetings with people with dementia when it came to the patient version of the guidelines. So we had one initially to discuss their preferences for the plain language version. So they were very much co-producers of the plain language version. They helped us to decide what we wanted to do for it. And of course, that resulted in us producing not only a patient version, so a booklet format, but also an easy read format, which is for people with learning disabilities, but is also useful for people with dementia who might not be able to concentrate for long periods of time. So it's shorter, it uses graphics to explain things. And of course, they wanted to produce an audio format as well, which we have done. So we had a pre-consultation meeting for the patient version before it went out for consultation, and again to make sure that we were getting it right, so that they very much helped us to write that. And we had the consultation meeting as well, and we had some 11 participants taking part in that. So I will now hand over to Marion, who will share her experience as a carer with you, and she will tell you a bit about what she contributed to the guideline. Marion.
Good afternoon, and thanks, Karen, for asking me to speak.
Sorry, Marion, you've popped
gone on
yourself
mute,
back
Marion.
on mute.
Sorry. Afternoon, I'll say again, and thank you, Karen, for asking me to speak about my involvement in the guidelines. As some background, as a lived experience representative on the new guidelines, I'd just like to explain my experience as an unpaid carer for my husband, Dave. These are our happy times with my two daughters, these photographs. In 2010, he attended a local memory clinic like most people do. He was alone, and he was told that his recent scan had showed small vessel disease and deep white ischemia, possibly early stages vascular dementia. So not even a firm diagnosis. A letter was sent to confirm this in writing, but no further appointments were made. We were left to digest this information on our own, do our own research into what this meant, and find our own support. I didn't see myself as a carer yet, just a concerned wife who was scared of what might lie ahead. Dave returned to the GP in 2014, 4 years later, and was then told he had dementia, vascular dementia and aphasia, but he was no longer at the early stages. That, I was told by the psychiatrist, was in 2010. Before retirement, Dave had retired at 55. He'd been a pilot with British Airways. He'd flown helicopters in the Royal Navy, then to oil rigs in the North Sea, and finally 757s around the world. I thought he was fit, healthy man. He loved the outdoors. He didn't smoke. He drank in moderation. He walked and he swam a mile every week. He didn't have a lot of friends, but his family was what was really important to him. And I couldn't understand why he developed this disease, which we thought at that time was an older person's illness, because his mother had been diagnosed in her 80s and had lived to almost 102. But dementia is not just an older person's disease, as we now know. By 2014, I'd begun to realise that I was now his full-time carer, and that the disease had progressed quite quickly over those 4 years. I had found local support in local carer groups run by voluntary organisations and charities, where sharing experiences helped me understand how the future might be. But you can never fully prepare for what might lie ahead, and the next 2 years were very challenging for all the family. And I include Dave in this too. He developed delirium, which is very common, and it seemed to cause a rapid downward spiral. His personality had changed too, and the gentle, polite, kind man became angry and an aggressive stranger. And this was quite frightening for me and for my daughters. But it must also have been really scary for Dave, who no longer felt safe in his own home. A 10-day spell in hospital, delirium ward, and antipsychotics, which didn't agree with him, took its toll, and he was then admitted to a mental health assessment ward. He was sectioned for 6 weeks, then 6 months, and came home doubly incontinent, having epileptic seizures for the first time in his life, and unable to walk almost anywhere without falling over. Those 2 years had a profound effect on the whole family, both mentally and physically. He did come home again, but only for a few months before being readmitted and then moved into a care home, where we celebrated our 40th wedding anniversary before he died in June 2019. So how I became involved. We received a request to NDCAN for a member to come forward who might be willing to take part in the development group. I'd been an active member of NDCAN since 2017 when Dave was in the care home, and I had a little more time to myself. NDCAN, I had been involved in the dementia strategies, the post-diagnostic support guidelines, training of dementia champions and DISLs, the Fair Dementia Care campaign, and had joined research into advanced dementia and more. We tried to speak out about the lack of support and resources and services, not just in a care home, but care at home. And this seemed like an ideal opportunity to get involved. I hadn't previously heard about SIGN. I didn't know that dementia guidelines existed or that they produced a patient version. I suppose I was still angry at the treatment my husband had endured in 2 hospital dementia assessment wards and in the hospital delirium ward. I was also angry at the lack of adequate support being offered, and I felt that I understood how hard it can be to cope with uncharacteristic behaviour, with violence and fear and loneliness and sometimes total despair. So why didn't many professionals seem to understand or care? I also believe that sharing experiences with other carers and the public, as well as carer education, as Karen mentioned, is just so important. Not to scare people, but to prepare them. In these guidelines, if these guidelines were used to inform medical professionals and help highlight where and what support would both help the person with dementia and their carers and family members, then I was interested in taking part. At the beginning of the 2.5-year process, I felt quite overwhelmed. I felt that I was a very small voice in a large group of health and social care professionals when attending the meetings, and I almost withdrew, but I'm so glad I didn't. My contribution wasn't to read the endless research papers that Adam mentioned or to evaluate their findings, more to listen to their evaluations and comment from personal experience point of view. And in some subjects, there just wasn't enough research evidence to provide good recommendations, and there was little mention of carer emotions or coping strategies in the research either. From a large set of questions initially, the group merged the topics, and eventually we were all allocated to 1 or 2 specific questions. I was in the subgroup dealing with grief, a topic I was really interested in because for so long I had felt that depression is often an easy diagnosis when guilt and grief are being experienced through the dementia disease progression. I felt that I was included in the discussions throughout and my opinions were taken into account. And once the clinical version was nearing completion, we started on the patient version with another subgroup in which I fully participated. I've since been involved in the consultation events online and the evaluation sessions, which have been amazing. And although it's been a long process, it's been a really interesting journey to see the guidelines developed from answers and questions to recommendations. These guidelines and their recommendations are based on good research evidence, but in some areas, research is sparse, so much more is needed. And I hope the recommendation for more research will be taken forward and people will come forward and participate too, because without participants, there can't be research either. Medical professionals can offer medication to treat their patients' mental and physical symptoms, but I'm delighted that in all sections of the guidelines, there is a note for clinicians to consider the main carer and the family too. The NHS and social care don't always have the services available to help or support families when they need them most, but there are many alternative therapies, as well as voluntary and charitable organisations who provide support, which is really readily available if clinicians know about them and can refer on or signpost their patients and families. And many of these are listed in these guidelines. So finally, most importantly for me, If the patient version of the guideline is not visible, then our development will have been wasted. I would like to see a copy hanging on every waiting room wall, in GP surgeries, dentists, opticians, clinics, hospital waiting rooms, anywhere that a member of the public has to sit for hours looking at bare walls. If someone's having concerns about their memory or their brain health in general, they might just pick this up and skim through the topics, or go online later and find out more. And they may feel encouraged to ask for help or contact one of the many organisations listed on the back for information and support. Knowledge is empowering. Let's share this knowledge, and let's talk about dementia. Thank you for listening to me.
Thank you so much, Karen and Marion. And Marion, thank you so much for sharing your personal story. There's lots of love for that in the chat. And everyone, can I just say that please let's action that call to action that Marion has just given us, to make sure that that patient version is out there and people see it. So now we're back over to Adam, who's going to provide us with an overview of the guidance itself. So thanks again, Karen and Marion. And if you've got any questions for any of our speakers, please just pop them into the chat.
Great, thanks, Lynn. And I suppose that's a really useful segue, and Marion's very powerful testimony of what she's been through. Hopefully you will see that as we talk through the recommendations from the guideline itself, which might seem a bit dry, but they are all rooted in that experience of what people have actually gone through. So I'm going to give you a bit of an overview of the sections, and then talk a little bit about the recommendations, and then come back to the call for action that we've just mentioned. So there's a few interesting points around this guideline that I just wanted to touch on. The first, as I said earlier, was around the pre-COVID acceptance. So this guideline was agreed. I sat in a room with real human beings before COVID, where we agreed that the guideline was going ahead. But the COVID process did delay things, unfortunately. We still finished it in good time, however. It's the first signed guideline that has been conducted entirely remotely. So all of the group meetings have been remote, and it is a shame that we missed our physical get together a couple of weeks ago, but hopefully something like that will happen at some point. And it's also the first guideline to be 50% qualitative. So SIGN have their expertise traditionally in quantitative literature. So whenever people are doing randomized controlled trials and the like, SIGN have been very, very good and have been at the forefront of that. But in this guideline, they were pushed into the space of looking at qualitative, something which is new, and I think that we'll come back to a little bit later. But definitely is a great thing for people with dementia and people interested in particularly mental health research, where quantitative research is harder to do. So there were a number of definitions that I wanted to go through, and I won't go through them all in depth, but just to let you know that the diagnosis of dementia that we used during the guideline, whenever we talked about it in the narrative, was the ICD-11 diagnosis. However, most of the research relates to ICD-10 or DSM-4 or even older versions, but we took them to be largely synonymous. We have a section talking about young onset dementia and what exactly we mean by that, and how we classify the stages of dementia. Whenever we talked about multi-professionals and healthcare professionals, we tried to include where we could the wide definition of health and social care professional. So whenever we read healthcare professional in this guideline, although that is often what the evidence points to, many of the recommendations are just as applicable to social care professionals, and indeed can be read by an even broader range of people. And that brings us to carers and young people and young carers. So for the guideline, we focused on informal and unpaid carer, and there's definitions further detailing that within the guideline itself. So There is no way I'm going to be able to cover 116 pages in 15 minutes. I'm glad that we managed to finish my last little section a little bit earlier, because it does give us a little bit more wiggle room, but I'm still not going to cover 116 pages. I can point you toward the recommendations, 121 points in total, 67 of them actual recommendations, and 6 of those we pulled out as key recommendations, which I'm going to go through in detail. There's 43 good practice points in there as well, and 11 information points, which you should have a look at if you have the chance. So I wondered now if we could do a little word cloud. So what I'm going to ask you to do is to type in one word. I'm hoping that my colleagues will put on, there we are, thank you very much. So the little word cloud box, if you just pop in one word that you think is the most important thing for you that the guidelines on dementia should try and cover. So just pop in the word and then press the submit button, and we'll see what comes up. So that's great. So it changes over time, and for people who haven't done this before, the more people that suggest a certain word, the bigger it becomes in the display. So that's good. Definitely support in the middle, which is great to see, because support is one of the things that we concentrated on very much. So that's great, and obviously people can review this again whenever they're watching the playback of the webinar. But hopefully we can actually get a little graphic of what we have there, but still support seems to be what most people are highlighting. So there's plenty of things in there with support. So thank you very much, everybody, for your contributions to that. Okay, so the guideline is split up into these broad headings. We've got the introduction and key recommendations, 6 of them at the very start, and then we go through the evidence and the full recommendations. And at the end, we've got sections on provision of information, which I think should be useful for everybody, and a little bit about implementing the guideline and the evidence base and the strategies that we use to develop the guideline. So I'm going to take you through each of the main sections then that give rise to the key recommendations and the recommendations themselves. And my hope here is that by going through these things, you'll have a bit of an idea about which section of the guideline you might want to start at. I recognise there isn't going to be everybody who's going to sit down today and to read through every single section of the guideline. There'll be different parts of it that are relevant to different people. But hopefully, if you pick and choose from various bits, you may well find some of these headings helpful. So we talk through the identification and assessment of suspected dementia. So we make points around history and examination, and we make some comments around in-person and remote assessment. And really the chief thing there is around the choice involved in in-person and remote assessment, that in some situations remote is okay and in some in-person is okay. We recommended a number of cognitive tests, and beside them we've put which setting you might want to use them in, what the various challenges or benefits with different tests are, and really what that is trying to reflect is that there is no single right cognitive test that's applicable for all people in all situations. So a bit of clinical judgment is required in those situations. And we also discuss about the diagnosis of dementia itself and how we convey that, around who to involve, particularly around not just that situation that Marion described of an individual and a doctor in a room speaking in complete isolation. It's about who else is involved in that, when and how, and the preparation. And that leads on to our first key recommendation, the identification and diagnosis of dementia. So I'll let you all read that, but really the chief thing I want you to take from this is the start of a theme about how these recommendations are person-centered, how they're keeping the person at the center, and really it is their need rather than the need of the clinic time or the doctor or the nurses involved or whomever else might be there, and it really should be centered around their care and helping them to, as it says there, continue with their life because we all know this is a condition which people live with for some time. So a helpful, hopefully, first key recommendation. Key recommendation 2 I'll go into and then move on to future care planning. Many people on the call will be familiar with the terminology anticipatory care planning. You may not be quite as familiar that the Chief Medical Officer has determined that it would be better for us in the future to talk about future care planning, as that's a much more accessible term to people. And I think there's a good rationale for that. So in the future, you can expect to see future care planning mentioned instead of anticipatory care planning. And this key recommendation reflects the fact that really we should be looking at anticipatory care planning as a longer term exercise. So not something that we sit down, we do once, and then we leave it and walk away. We need to start discussions early. So we're talking about post-diagnostic support even, and maybe even earlier than that. And then try and develop that as the understanding of the condition progresses, but always bearing in mind that the capacity of the person with dementia is not static and it will change as time goes on. So that's a difficult thing for us, trying to help and work with people with dementia and their families, to try and keep in our minds that we need to enjoy the present. We need to encourage people to live well at the moment, but there is a race against time as well to try and help people before they get to the situation where we run out of that time. So we have a chapter on further investigative procedures. Diagnosing suspected Alzheimer's disease. We have gone into some more about the structural and functional imaging and cerebrospinal fluid that we haven't really talked about before in Scotland, certainly. And we also have brief guidance on the various other types of dementia as well as a little bit on consideration of genetic testing, which at the moment is still so different from area to area. We've had to recommend that people follow their own local area guidance on genetic testing. The post-diagnostic support section, everybody will be familiar that we've had our recommendations, our process around post-diagnostic support and the 5 pillars model for quite a number of years now, and that's something that people in Scotland can expect. That isn't the case in other parts of the world. But we've gone through the evidence around post-diagnostic support and what can be included in there. And obviously, as Marion mentioned earlier, we can't make recommendations about things where there is no evidence. So just because there is no evidence about it doesn't mean that it doesn't work. But what we can say is that these things definitely do work, and they are helpful. So hopefully there will be some things in there that will help people shape the care that they provide. And again, I saw a mention in the word cloud that we did around funding as well. Many of the recommendations that we have here are about changing things which we already do, rather than implementing new things over and above what we have in place. So key recommendation 3 is about post-diagnostic support. And you'll notice a few things there that we've been talking about for quite a wee while, but are now in this guideline as something which we should positively look toward and try and incorporate into our service around continuity of care, making sure that people have that available as a single point of contact, and that the people who are providing the post-diagnostic support should have the expertise, the knowledge and the skills that they need to actually deliver what is needed. Moving on to section 6, the non-pharmacological approaches for distressed behaviour. So we looked at a range of different things under this as well. And I suppose one of the things to point out, which is perhaps particularly of interest to people in Scotland, is that we didn't recommend a particular model with regard to non-pharmacological approaches. So be aware that there are a few models, such as, for example, the Newcastle model, which are promoted, but instead, because there is limited evidence around which model in particular is of most benefit, instead we keep to broad headings of things which we know that help, which I'll go on to in just a wee moment. But key recommendation 5, hopefully people will see in this some of the things which are already being done in many areas, but this adds additional strength and weight toward those practices. So around tailored activities based on comprehensive structured assessments. So trying to take each individual as an individual rather than trying to impose a one-size-fits-all approach on everyone is really what we're talking about here. And at the bottom there, you'll notice as well for carers as well, trying to use psychoeducation and skills for them so that they can be part of the care team, so that they can help the person who they really want to be helping as well. So again, coming back to these things which people will find are hopefully already familiar in some of the models that they're already familiar with and have used around problem solving and triggers and coping strategies for stress behaviors in carers and people in the family as well. Hopefully, as I say, people will be familiar with all of these approaches, but this really supports in evidence that this is what we should be doing. Grief and dementia, Marion mentioned earlier, and this has been one of the other cutting edge areas that we've gone into in this guideline that hasn't really been talked about before. Anticipatory grief is the catch-all term, but we really talk about pre-death grief as a unique concept, both for people with dementia themselves and for people who care for people with dementia as well. And one of the steps of this is trying to raise awareness of this concept in everyone in our society, really, because it's something that people don't talk about very much. Instinctively, people acknowledge that this is sort of what happens, that it is like a grieving process, but they're often not brave enough to actually put the word grief onto this, and we are in this guideline, and hopefully it will give validation for people who are experiencing it, but also the impetus for people who are delivering the care to actually seek out training in this and to actually be more mindful of it whenever they're helping people. And it leads us on to our fourth key recommendation around grief and dementia. And as I said, number one thing is to try and raise awareness of this and to validate it, but also being aware that there are particular stages which people find more difficult, not just because transitions are difficult for everyone, but also because at these particular phases, so as dementia is becoming more severe and whenever we have a transition, such as people moving into long-term care, the grief experience actually becomes worse. It actually goes in a big step, and people need additional support around that and understanding that it is a grieving process and unique in that way. In section 8, we talk about the changing needs of people with dementia. So reflecting the fact that dementia is a progressive condition and that as people move along, it is different for every person. We don't find any particular tools which are helpful in that regard. So it is really about individual and person-centered care in this regard. So we're looking at palliative and end-of-life approaches, but we're also looking at transitions between care settings, and we also come back to some of the language around advanced, anticipatory and future care planning, which people will find useful going ahead. So some next steps for you before I hand over to the next speaker. There's a lot of work going on promotion. This is from HIS and ourselves who have worked on the guideline as well as sign. But if I could ask all of you as well to, I know that there have already been plenty of comments in the chat about trying to get the information into the hands of professionals and people who use the service as well. We've done some work on media as well to try and publicise the guideline, and we're working closely with HIS, which you'll hear about in a wee minute. As you heard from the Minister earlier, we are linking with the dementia strategy and the work plan, and we hope to be influential there and to try and make sure that we have actual policy drivers that will help people with dementia get what they needed. But above all else, we need all of the people here on this call, all 348 of you, to try and push this further, because dementia is one of these conditions that is now part of the consciousness, but it's very much always there now, but rarely at the front, and we need to try and push it to the front because the problem, the challenges are going to get more difficult, and the people with dementia are not going to go anywhere. They still need our help and they still need our support. And it's through pieces of work like this guideline that we try and improve the care for people and try and highlight people's needs. So thank you very much, and I will hand back to Lynn.
Thank you so much, Adam, for that overview of the guideline. Yeah, quite a challenge to fit all of that into 15 minutes, but you did a grand job. And now I'd like to pass on to Dr. Anne Wales. Anne is the programme lead for the Right Decision Service, and she's going to talk about how her service might support some of the implementation. So thank you, Anne, over to you.
Okay, thank you very much, Lynn. Yes, so I'm going to share with you some thoughts and early preview work around how we could deliver the Sign Dementia Guideline as a decision support toolkit through the Right Decision Service. Although it's me speaking today, in the interests of the short time we have, I do want to highlight that everything that I show you in terms of the preview of the decision support tool has been created by Kirsty Little-Allen, a project support officer in the Right Decision Service, and Kirsty has a substantive role with the Sign team itself. So for any of you who aren't aware of the Right Decision Service, this is a national platform that delivers decision support tools. It's funded by Scottish Government to be a Once for Scotland source of digital tools that bring evidence to the fingertips of practitioners and citizens to support safe, effective and personalised decisions. So it's really all about getting the high quality validated evidence and guidance in resources like your Sign Dementia Guideline more readily into action through the decisions that practitioners and citizens make on a day-to-day basis. The evidence is delivered in decision-ready format through everyday technology. We'll be focusing just now mainly on web and mobile app delivery, but some of our tools are also delivered through electronic care record systems. The mandate for the Right Decision Service comes both from digital health and care in the form of the digital delivery plan and the data strategy for health and social care. And also the Right Decision Service is strongly endorsed in the vision and action plan for value-based health and care. So we have a strong policy mandate. From the point of view of the clinician using the Right Decision Service or the social care practitioner, it's most likely that you would see it either through the web interface, which you see on the left of this screen, the Right Decisions for Health and Care website, or you can download it from the app stores as a mobile app, which you see on the right-hand side of the screen. Both of these, the web and the mobile versions, deliver the same content. Now over 180 individual decision support toolkits, all available through this Once for Scotland web and mobile platform. We already deliver through the Right Decision Service a number of Sign guidelines as decision support tools. Hopefully you can get a glimpse of them from the screenshots here. Again, accessible via the web and for downloading through the mobile app. For the Dementia Guideline, we've put together some early sort of draft pointers as to how we could deliver this guideline content as a decision support toolkit through the Right Decision Service. So on the left, you will see the web version with each of the key chapters that contains recommendations represented by a tile or tab, as you can see here. And on the right, you see the same content presented in mobile format. So hopefully you're recognizing now several of the elements and chapters that were just described by Dr. Daly, the key recommendations, identification and diagnosis of dementia, further investigative procedures, etc. Just to show you how these tools are designed to make it quick and easy for the frontline practitioner to get quickly to the specific recommendation of interest. First of all, the key recommendations section. Here we've simply drawn these key recommendations together in a nicely formatted page that hopefully is easy for clinicians to scroll through and quickly jump to the key recommendation of interest to them at any one time. If we focus in on any one section, such as identification and diagnosis of dementia, the clinician is presented then with key headings drawn from the guideline itself, and beneath these headings they will find the key recommendations for action that pertain to that particular topic. One of the things we need to understand better through stakeholder consultation is whether for that day-to-day decision making it's sufficient simply to have the recommendations listed in an accessible format like this, or would you also want some supporting contextual information? This is just a quick snapshot of some of the content from the grief in dementia section, knowing that this is such a key and innovative part of the guideline. So here, for example, in the pre-death grief section, the clinician can go very quickly to the recommendation about pre-death grief in carers of people with dementia. We've also included a link here through to some of the context-specific information from the full guideline, just an example of how that could work. If the clinician wants to move to a different section, for example, around pre-death grief and depression in a carer, they can go very quickly to that section, open it up and see the recommendation and the good practice point listed. Another great benefit of the Right Decision Service, over and above bringing these evidence-based recommendations to the clinician's fingertips, really putting that in the hands of the clinician to support frontline decision making. Another great benefit of the Right Decision Service is that it can bring together related resources about dementia. So, for example, here I've just done a little search for dementia. It's brought up the SIGN guideline toolkit, and alongside that, I've just put in a placeholder tab for some work that we're currently initiating with the Dementia Improvement Programme to bring together improvement resources there. And you'll also see, hopefully you can make out on the right-hand side, we have a collection of resources aimed at people living with dementia and carers around supporting living well with dementia. So you can bring all of these good quality resources together and make connections between them to support a kind of richer care experience. So in summary, benefits of providing and accessing guidance through the Right Decision Service. includes the ability to navigate quickly to specific answers and specific information needed for decisions at point of care. There's the great benefit of downloadable mobile access for use in the community and also in hospital sites where internet connectivity is poor. And also this ability to make links between related resources, for example, improvement resources and resources aimed at people living with dementia and carers. So hopefully all of these things seem useful and relevant to practitioners and indeed people with lived experience on the call. So just a little opportunity for yourselves to input as I finish here. It'd be really good, based on the little taster that you've seen in the screenshots today, who do you think might use that SIGN Dementia Decision Support Toolkit and for what purpose? So if we just take 30 seconds for you to have a think about those questions and type your answers into the chat, please. But don't press send until I say. Okay, so I'll give you 30 seconds to think of your answer to one or both of these questions, and then I'll ask you to send them through and we'll see what people's thoughts are. Okay. Well, I assume people are already putting their answers into chat. If you could just hold till I say to press send. That's great to see that what's coming through already. Okay, so people want to press send now, if you haven't already done so, and we'll see everybody's thoughts. My goodness, lots of suggestions. So interest from carers, or use by carers, as well as healthcare practitioners of a whole variety of types. Really interesting to see the emphasis actually on people with lived experience and carers. Thank you so much, everybody. That's really, really useful. It's all healthcare staff, indeed. Great. So thank you very much indeed, everyone. That's really helpful, and I'm especially interested to see that emphasis on a wider use beyond practitioners. Thank you. Are you taking back control now, Lynn?
Yes, the
Right.
team will. Thank you so much, Anne, and my team will be giving me a row because I haven't switched my notifications off, so you might hear some pinging in the next couple of seconds. But thank you so much, Anne. That was really, really interesting, and it'll be, you know, really great to see how that supports that kind of knowledge mobilisation and that knowledge transfer. There was a question in the chat about, is there a mechanism to allow additional content to be added that would benefit the workforce? I presume that's a yes, that this is something that could be added to.
Absolutely, yes. Potentially that could go in as supporting resources in the guideline toolkit, if that was acceptable to SIGN, or we can create a linked toolkit with supporting resources. So yes, very definitely do get in touch. You've got my contact details there if you'd like to discuss that further.
That's great. And there's a couple of queries about the website asking for a password and some queries around that.
Yes, what I've shown you today is work in progress. It's by no means finalised. It was just so that we had some taster content to show you in advance. So if it's okay, what I'd like to do is just check with the SIGN team if they're happy for me to share the password with the group, so that you can go in and browse the work we've done already and give fuller feedback.
That's super. Thank you so much, Anne. And now over to a couple of members of my own team, over to Julie Miller and Marie Innes. Julie is an improvement advisor and she works with me on the community parts of our portfolio of work. And Marie is a senior improvement advisor and she works on our hospitals work. So over to you, Julie and Marie.
Thanks very much, Lynn. And yes, as the slide suggests, we're just going to share some examples of current work that Focus on Dementia are doing that support putting the guideline into practice. So as Lynn says, I'm Julie. I'm an improvement advisor with Focus on Dementia, and I'm going to briefly share some of these examples. And it's what we think supports the implementation of the new guideline. And as I talk, links will appear into the chat because I'm going to mention many resources that we've already produced. So hopefully you can have a look in more detail at those after the webinar. So in Focus on Dementia, we have an ongoing programme of work to improve post-diagnostic support and care coordination. And it's fair to say that much of our work does align to many of the 21 post-diagnostic support recommendations and 9 best practice points that are in the SIGN guideline. So for example, we've produced what we call a change package in the last year that wraps up all of the learning from our post-diagnostic support and care coordination work over the past few years. And this includes guidance and change ideas for practitioners who wish to make improvements to their services and to better coordinate care and support. We are currently running a specific post-diagnostic support improvement programme working with 3 selected sites, and that's Dundee, Edinburgh and Lanarkshire. And the improvement aims for each site certainly chime with the SIGN guideline recommendations. Dundee team, for example, the PDS team, they are focusing on improving care coordination. They're currently building connections with primary care and with speech and language therapy. They're also focusing on equality. They're looking at creating champions in the team for different groups, for like the deaf community, for example, learning disability and care homes. So lots of things there that chime with the guideline. NHS Lanarkshire have set up a new Pan-Lanarkshire PDS team, and we're helping them to apply quality improvement methodology to develop a high quality post-diagnostic support service. Edinburgh Health and Social Care Partnership are focusing on improving equitable access to post-diagnostic support, recording and information sharing and transitions at the end of post-diagnostic support. So through this work that we're doing with the sites, we'll continue to heed the SIGN recommendations and make sure that we're working to align with those. Another piece of work that we've been doing and we've been working on over the past few years really is, and it'll hopefully be familiar to many of you in the post-diagnostic support world, is the post-diagnostic support quality improvement framework. Now, I was pleased to see that this is referenced in the SIGN guideline as a useful tool for services wishing to improve the quality of what they do around post-diagnostic support. It's a self-assessment guide that's already used by many practitioners, and also it's mentioned in the new dementia strategy, which is also promoting its use. But yeah, the guideline itself already supports many SIGN recommendations, good practice points and information points that are in the SIGN guideline. So hopefully that's reassuring actually for people on the call who know about the framework and have used it. It's reassuring to know that many criteria in the framework do fit with the SIGN recommendations, such as ensuring PDS for maintaining normal life in the community, maintaining identity, relationships and social life, staying active and healthy and engaging in meaningful activities, and also for things like respect to balance and safety with independence, for example, walking outside and driving. All of those things are already in the framework. But that said, we are reviewing the framework. We try to review it every 3 years, so another version will be due out next year. So we are going to be in the process of reviewing the framework over the course of next year, and we'll be taking the SIGN recommendations into account to check, what's missing, what else should be in that quality improvement framework for post-diagnostic support. Things like pre-death grief that Adam has already talked about, and Marion, and also looking a wee bit more around the interlinked needs of carers when we're delivering post-diagnostic support, and also things like physical needs. Have we got strong enough messages in there around that area of support? So we're hoping that a 3rd edition of the framework will be out in autumn winter next year. Other recommendations in the guideline relate to care coordination, and again we've got much learning from testing around this, and this 12 critical success factors resource that's on the slide here is just one example of a focus on dementia resource that aligns to the recommendation that there should be a well-defined care pathway, single point of contact and continuity of care. So everything we do in focus on dementia is underpinned by what we call a learning system, which is how we share and spread learning. And this slide here just shows the range of things that we do to share that learning. And webinars like this one is one of them. So we'll continue to match our learning system activity to the new guideline and to support its implementation. For example, we're looking to have a webinar in the new year around key information summaries and future care planning and how that can be better linked to the post-diagnostic support role. But please have a look at the recorded webinars that we've held in the past, because really most of them all relate to the recommendations in the guideline in some way. So hopefully that's been helpful, but please post any questions or comments into the chat for myself and Marie, who I'll now hand over to tell you a bit more about the dementia in hospitals work. Thank you. Hope you're on mute, Marie, I think.
Oh, well, something had to do it, didn't they? So thanks, everybody. My name's Marie Innes, as Senior Improvement Advisor, and as Julie was saying, so I'm working on the hospitals programme and the Focus on Dementia team. So today I'm going to be sharing a brief summary of the work from an improvement programme that Scottish Government commissioned us to deliver. And then I'll describe how it links with the recommendations in the signed guideline that we've already heard about. So the aim of the programme was to improve hospital care for people with dementia. It was planned originally to run from September 2019 to September 2021 across 3 types of setting: acute community hospitals and specialist dementia units. Very early in the programme, we faced the onset of the COVID-19 pandemic, and as all the teams were based in hospitals, as you can imagine, had a significant impact on the programme. So we paused the work twice and it finished in March this year. So we worked with a range of stakeholders to agree the aim based on the priorities that were emerging during the pandemic. And we learned that the visiting restrictions that were in place meant that it was more difficult for staff to get to know what was important for people with dementia who were admitted to the wards, and therefore to provide truly person-centred care. So as a result, we agreed to focus the programme on one priority, which was person-centred care planning. And our theory was that improved person-centred care planning would reduce stress and distress for people with dementia. And the specific aim of the programme, as you see in the slide, was that hospital care for people with dementia will be informed by a personalised care plan, which reflects their strengths, needs, wishes and choices. And this person-centred approach would support the prevention and management of stress and distress. So if we now look at the signed guideline and the recommendation for distress behaviours that Adam spoke about earlier, the recommendation includes that for managing distressed behaviour symptoms in people with dementia, tailored activities based on a comprehensive structured assessment may be considered. Activities should be individualised, focus on preserved capabilities and consider previous roles, interests and preferences. So the teams involved in the hospital programme used a quality improvement approach to test and implement a range of improvement ideas, and many of them focused on using a document called Getting to Know Me to gather person-centred information about individual, and they introduced processes to ensure that that document was completed. Some of the teams created life storybooks or memory boxes to support meaningful activities. Another team developed an activity planner which laid out information about how individuals like to spend their time and how staff could support them to do that. And one team focused on the fact that not all members of the team could easily access the personal information that they held in the notes. So they developed a poster to stay by the patient bedside so that all team members could use this in their interactions for conversations or as part of goal setting. And there's an example, I know it's very small, but just to give you an example of how the poster looked. So As you can see, that was just, again, a very brief example of how some of the recommendations in the signed guideline connect with the work that we're doing. And although that hospital programme is complete, we are still working on next steps for our hospital improvement work. So as we've said, this is about supporting the dementia strategy and the signed guideline implementation. So we are currently and will continue to share the learning from the hospital programme across Scotland, and we're doing that through webinars and events like this. We have updated our web pages and included all of the outputs from the programme, including a 6 high impact change document and a change package like the other programme Julie described. We're posting information on social media. We are currently updating our Dementia in Hospitals toolkit, which was developed from a previous programme and has been updated with work from the current programme. And we've also been linking in with other national programmes across Healthcare Improvement Scotland and other organisations and partner organisations to share the work and ensure that we can continue to implement the good practice that we were supporting teams to develop during the programme. So as a very quick run through of a long programme, but there's lots of information, as I said, on our web pages, and the links to that will be posted in the chat. And I will now pass back to Lynn to wrap up this session.
Thank you so much, Marie. So that brings us to the end of our webinar today. I'd like to thank our amazing speakers today. I would also like to thank the fabulous Focus and Dementia team for working so hard behind the scenes to make today's webinar happen. And I would like to thank all of you for taking time out of your busy schedules to join us today. I'd also like to thank our sign colleagues, so there's many of our sign colleagues on the webinar today, for working so hard to make this guideline happen for the dementia community. I think we all, those of us who are in the development group, get our eyes opened about just how much hard work goes into the development of these guidelines. So thank you so much for that, and also for answering some of the questions in the chat today. In the true spirit of improvement, we would be really grateful if you would spend just a few minutes to let us know what you thought of today's webinar. Just click on the link in the Q&A box to access a very, very brief evaluation. And if you're not already a member of our network and would like to keep in touch, just drop us an email and we'll add you on. And to finish, a call to action. We need all of you to help raise awareness of the guideline and support its implementation. So we'd like you to consider what your contribution to that will be. Thanks again, take care and goodbye.